Defining diabetes, truly it is the way the body uses nutrients from the foods. It's a complex disorder of carbohydrates, proteins, and fat metabolism. Carbohydrates are found in the foods that contain sugars and starches, so breads, fruits, milk, rice, that type of thing. In the process of digesting carbohydrates, they are broken down into their basic form, glucose. Anything that ends in OSE is a sugar. I am so glad I don't have to get into the whole coffee mate thing here, because that stuff, the first ingredient is a sugar. It has galactose, fructose, sucrose, all of them. Anything that ends in OSE is a sugar. And that's what our body in its wisdom does. We know that when we take food in, it goes into our stomachs up here, and our pancreas is right underneath it. It's the pancreas that releases the insulin, hopefully all the time. You have a high blood sugar level because of defective insulin secretion, meaning not enough coming from the pancreas, or the action of the insulin coming from the pancreas is little or nil. Chronic hyperglycemia of diabetes is associated with a significant long-term sequelae or following of events, particularly damage, dysfunction, and failure of various organs, especially the eyes, kidneys, nerves, heart, and blood. So those are where we hear that generally high blood sugars of diabetes are affected. Type 1 diabetes, meaning, again, looking at the beta cells of the pancreas, they're destroyed, so there's actually maybe no more insulin being produced. They might have developed it as an autoimmune disorder. They are dependent on what's called exogenous insulin, which means giving themselves an insulin injection every day, or wearing a pump that calibrates it over the course of a day. They are more ketosis prone, which means that the body can go into an acidic level quite rapidly. And they may also have a family history of diabetes. Type 2 diabetes has many more characteristics to it. It often does look at having an impaired beta cell production, which means the pancreas isn't producing either enough or it's ineffective, the insulin that's being produced. They may be insulin resistant. They are not usually dependent on exogenous insulin initially. So although they're not dependent on exogenous insulin, they may need insulin injections to control their hyperglycemia on a daily basis. Many are obese. They are not usually prone to ketosis, and they may also have a family history of diabetes. So it's important just to make note here that all the words that we've heard for many years, juvenile diabetes, insulin-dependent diabetes, type 1 NIDM, type 2, adult onset diabetes, borderline diabetes, I have fun with that one, and chemical diabetes are no longer really accurate terms. I know you've heard them. Doctors still will use your borderline. You either have diabetes in very good control and you don't require any insulin, no medication, and it's all managed with diet and exercise. That's great, but it doesn't mean you don't have diabetes. It's really, really important to note that when we hear about people being diagnosed with diabetes, that they're actually getting a wake-up call, and to help people realize that it's not a life sentence. It's a lifestyle. Start with a history, a food history, a journal for the week. We talk about what we're going to add into the diet, and slowly we're going to just push those other ones out of there, but it has to be a gentle thing, truly. Many people get it together and go on and live very healthy, productive, long lives without all the complications of diabetes. So insulin regulation in the body. It controls the level of glucose in the body by allowing glucose to cross the cell membranes, and the glucose travels across the cell, nourishes the cells, and then takes the toxic substances out. It also works by converting glucose into glycogen. So you have excess glucose, the body says, okay, let's put this in the liver and store it. It also assisting in the conversion of excess glucose to fat. That is what you get when you have too much glucose in your diet, is you get fat. Preventing proteins from being used for energy. So the diagnosis of diabetes, they will have you come in and do an impaired fasting glucose, which means you won't eat for 8 hours, and they will take your blood. An ideal blood sugar is between 4 and 7. If you haven't eaten for 8 hours, they're looking at your blood sugar being around 4 or 5. If it's at 6 already, over 6, and you haven't eaten, then you're probably having diabetes. Then an impaired glucose tolerance test is after you fast for 8 hours and they test your blood sugar. Now they give you that syrupy drink stuff, and it's a measured amount of giving you a 75-gram load of glucose. And then 2 hours after that, they're going to do another blood sugar, and that one there would be greater than 7. And again, you know, most of us who do not have diabetes took in that 75-gram glucose thing, the body would still hold the blood sugar and bring it down because it would be able to produce enough insulin to manage that glucose in the body. Type 2 diabetes has reached epidemic proportions. There's a prevalence of 3 to 5 times higher than that of the general population, and it's high as 26% in individual populations. We're seeing children as young as 8, and that with type 2, not type 1, type 2 diabetes. Twice the risk of developing gestational diabetes. It develops when you're pregnant, it goes away afterwards. Pre-diabetes, so we have it here, and the doctors will say you have a pre-diabetes, which means that you have indicators that put you at a higher risk. If you have the genetics, if it's in your family, if you know your parents had it or you had gestational diabetes, I like the fine line. You walk a fine line is really what you do. So it's a metabolic syndrome, abdominal obesity, hypertension, which is high blood pressure, dyslipidemia, which means high cholesterol count, insulin resistance, and dysglycemia, which means an abnormal blood sugar. High rates of diabetes in Aboriginal communities is likely the result of interaction of genetic susceptibility and local genetic mutations with the numerous stressors and lifestyle factors. So all that is talking about, you know, a predisposition in terms of your genetics and your family, as well as a change in diet. We get this all the time. How did all this happen to us? Well, if you back up even 100 years in all cultures, it was very different. You had to work to eat. You didn't just get to turn on a microwave and push start. So decreased rates of physical activity, that's what we were saying, and the replacement of traditional food with highly refined foods equal high rates of obesity and diabetes risks factors in children. Recommended screening. So we're looking for identification of modifiable risk factors starting in childhood. So obesity, how can we, you know, encourage the young ones to get outside and play again and come in when it's dinner time and not until. Just go and play. Elevated BMIs, we know that to be the body mass index. So what is your BMI and where does it need to be? Lack of physical activity, and just general unhealthy eating. Fast foods are convenient, but they are not healthy. Then you have an impaired fasting glucose and an impaired glucose tolerance. That's what those last two are, and they can be modified. And screening for diabetes with a fasting plasma glucose test should be considered every 1 to 2 years with a person with increased risk factors. So if you've got it in your family, if you're overweight, if you've been through stress in your life, just check your blood sugar every year. It's not hard to test a blood sugar. You don't really need to go see a doctor to do that. You can go to your public health nurse, your community health representative, somebody in your community, and start with that screening first. Optimal glucose control is fundamental to the management of diabetes. Recommended targets for glycemic control, A1C. A1C is a measure they take your blood, and it shows for the last 3 months what's the average have been. It should be below 7. A fasting or a post glucose or post-eating, that's what that means, should be between 4 and 7. So your curves are nice and slow, you're gentle. You don't want any peaks and valleys, or that's exactly what you get in life. So the 2-hour postprandial, which means after you eat, should be between 5 and 10. Between 5 and 8 if the A1C targets are not being met. So no matter what you've eaten, the 2 hours after, it should still be under 10. So healthy eating, avoid the diet mentality. Over the course of my life, I have lost 50 pounds about 5 times. I'm not very proud of that, but I used the diet mentality and it worked very well. I seem to know how to do that, but I couldn't manage to keep it off. So I'm looking at it all differently this time and trying to change my lifestyle, change my eating habits, and make changes so it's a permanent change, not just an immediate change. And then there's regular follow-ups with healthcare providers. You know, you have to push for what you need and for the follow-ups you need. If they don't come, you've got to ask for it. And if you don't get it, be pleasantly persistent. And if they still say no, make sure they tell you why. You want to do some regular screening programs. Health fairs and schools are a great way to get that education out there. The Aboriginal Diabetes Initiative, community partnerships with wonderful groups like SOADI. CAWC stands for the Canadian Association of Wound Care, and it is their form that we're going to be using this week, and I know that SOADI's been involved in the development of some of their work that they've done. And the Canadian Diabetes Association, all with wonderful literature about diabetes and health. And secondary prevention, calling in all the troops. And this is where, how many here in nursing would say that they honestly got a good nutrition course while they were in nursing? Come on, ladies, where the hands? See, we didn't get it, did we? It's not been an easy curve, really. There's lots to learn about out there. So that is what I look at, trying to bring more education in, is how to cook differently. Then you want to identify those at risk for development of complications of diabetes. So those would be people that may have other compromising factors as well. Be aware that the development of complications, whether it's neuropathy, now that's the nerves, their absence of feeling or sensation. Nephropathy has to do with the kidneys, and retinopathy has to do with the eyes. CVD is cardiovascular diseases, PVD, peripheral vascular diseases. It's an insidious process, which means it happens slowly, it compounds, and at the beginning there's often no symptoms accompanying any of these things. Well, here's some more recommended resources, and I encourage you to make sure you have a list of all of these. So we've mentioned them, the Canadian Diabetes Association. For the nurses, the RNAO has a great clinical practice guidelines. SOADI has an amazing website. If you've not been through it all, take a day. It's wonderful. Educate yourself. Make sure that you know what it is you want. If you're struggling with something, research it. And ADI is the Aboriginal Diabetes Initiative's conferences. They're fun to go to, lots to learn. And your industry reps, don't forget them. Make sure you know who your industry rep is for your area, especially for glucometers. I've heard people say, I can't afford one. You don't have to buy a glucometer. They will give you a glucometer because it's the strips and the lancets they're making the money on. And if you can get the doctor to write you a prescription, that'll be covered for you. If you don't like the monitor you have, then find the company of the monitor you like and talk to them. Canadian Association of Wound Care, that's for wounds and things like that. It's a big organization, and they have just developed the new diabetes quarterly or foot care, whole Canadian-wide foot care component to their website. We cannot cure diabetes, but we can teach our clients to control it. Education on all fronts is the key. Complications of diabetes are, for the most part, and can be prevented. And we have an uphill battle to convince our clients that the development of diabetes and or the complications of diabetes is not inevitable. Because they were diagnosed with diabetes does not mean they will get all the complications. If they can take it seriously, get the blood sugar down under 10 and keep it under 10, and you're negotiating with the clients to try to increase activities. But I have absolutely seen people go from being on insulin, change their lifestyle, went off of insulin, was only on medication like metformin and that, kept changing their lifestyle, came off metformin, and are no longer on any medication. Are they cured of diabetes? You have to ask me as a nurse. I'd say, no, you're not cured. That means if you decided to eat a payload of food again, your pancreas would probably still have trouble managing certain intakes. But it means that you have done an absolutely superlative job of learning about what your body can take in and what you need to put out in terms of exercise. That person would deserve a ribbon of excellence, really. Your reason to change has to be greater than your reason to stay the same.